Good day. My name is Michelle Lavander. I'm the director of the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Reporting on the Health Equity Backlash. Starting on his first day in office, President Trump has unleashed a barrage of changes that are dramatically reshaping medical research and healthcare in this country. Programs, funding, and initiatives deemed related to equity or DEI have been targeted, with grants terminated, federal health databases taken down, and initiatives halted. Amid the flurry of executive orders, shuttered programs, and agency firings, it can be hard to track the long-term implications of change, with legal challenges only creating even more uncertainty. In this webinar, we'll assess where we are now and what this upheaval might mean for long-standing efforts to address inequities in healthcare, from the toll of chronic illness for some populations to maternal mortality for communities of color. We'll explore what changes might mean for patients and communities and point the way to reporting opportunities and storylines that can bring these developments home for your audiences. We'll hear from one of the nation's most prominent public health voices, a journalist whose coverage has come to define the health equity beat, and a physician leader and expert on chronic disease and healthcare disparities. Let me introduce them. We'll be hearing from Dr. Georges Benjamin, the Executive Director of the American Public Health Association, the nation's oldest and largest organization of public health professionals. Dr. Benjamin has served in this role since 2002. Before that, he served as Secretary of the Maryland Department of Health and Mental Hygiene, where he played a key role developing Maryland's bioterrorism plan. He is board certified in internal medicine and a fellow of the American College of Physicians. He also serves on the boards of Research America, Partnership for Prevention, and the Reagan-Udall Foundation. He's a member of the Institute of Medicine of the National Academies of Science. Usha Lee McFarlane is a national science correspondent for Stat News, covering the impact of race and racism on science and medicine. She previously reported for the Los Angeles Times, Boston Globe, Knight Ridder Washington Bureau, and the San Antonio Light. Her work on the disease state of the world's oceans earned the 2007 Pulitzer Prize for Explanatory Journalism, and her reporting on structural racism in medicine won the 2021 award for beat reporting from the Association for Healthcare Journalists. She was also previously an artist in residence at the University of Washington. Dr. Monica Peek specializes in internal medicine and preventive health for adults at the University of Chicago Medicine, where she serves as the L&H Block Professor of Health Justice. She also serves as the Associate Director of the Chicago Center for Diabetes Translational Research. As principal investigator on 2 multi-year clinical studies, Dr. Peek is working on improving diabetes care and medical outcomes for patients on the south side of Chicago. She's one of 2 inaugural faculty fellows at the Bucksbaum-Siegler Institute for Clinical Excellence at the University of Chicago Medicine, where she explores how racial and cultural barriers impact physician-patient relations and shared decision-making. In 2002, Dr. Peek was elected to the National Academy of Medicine. This webinar is made possible thanks to the generous support of the Commonwealth Fund and the California Endowment. We'll be archiving this conversation later today at centerforhealthjournalism.org. A word about our format today. We'll be hearing from our speakers first, and then we'll turn it over to our audience for questions. Feel free to share your questions and any kind of technical issues in the Q&A function in Zoom. And now let's get underway. Usha, let's start with you. You cover health disparities and health equity as a beat. Take us through some of the major changes that we've seen since President Trump came into office. What has the backlash against DEI and health equity meant for what was a growing effort to close the longstanding gaps in health and well-being in this country?
Thanks so much, Michelle. And I'm just really honored to be part of this incredible panel. So thanks for having me. And I'm going to share my screen. Okay, well, you know, the way people are describing what's been going on since January 20th is a flood, a fire hose. I've never heard the word unprecedented used so many times, but those things are all true. And I think what we really need to do at this point, it's been a few months now, is sort of take a minute and stop and look at it in in a kind of a larger perspective. And let's see, okay, my slides are not advancing. Okay. Sorry about that. Let me try again. Okay. This worked very well when we practiced. Okay. Can everyone see that yet? Am I sharing? Ah, sorry, that's my beautiful daughter. All right, let me try this.
Now we see it.
Okay. My slides are just not advancing. I may have to just look at my slides and talk to
Do
you.
you want to just shoot them to us and we'll get them up while you get going?
Okay, sure.
I just put the emails in the chat.
Okay, hold on one second. I really apologize.
And I think actually, I think.
Okay.
The second one that I sent you is the correct one.
Okay.
And Dr. Benjamin and Monica, just in case it's on our end, if you want to send us your PowerPoints too right now, that will just be a good belt and suspenders move, I think.
I just sent them.
While we're waiting for this, I'm just wondering if anybody wants to share in the Q&A anything about what they would say is the most notable issue that they're encountering in their community right now when it comes to all these programs and this dramatic shift. I think it can inform our conversation. So feel free to post a quick note, and we hope to be underway just momentarily with the more formal presentation.
Let me try to share.
I'm seeing Becky Shepard is saying a lack of access to data, which is a huge concern. And just so you all know, we're having a whole separate webinar on this very topic under this series.
Okay, can you see that while I'm waiting for the slides?
I can see what looks like President Trump signing something.
Okay, right. So basically what we did was, we'd been reporting on everything that had been happening, the cuts to the federal workforce, the cuts to grants, and in advance of the 100 days of the Trump administration, we decided to just stop and kind of put together every single thing that had happened. I'm gonna scroll through it slowly, and we're gonna send this link. People found this very helpful to just put in perspective and see how breathtakingly fast everything had happened. I'm not going to scroll through the whole thing, but we're still in January. You can see how high this little tab is. But the web page is taken down, the DEI scrubbing, the grants, frozen, the whole grant making process. Major supporters of science previously, like the Howard Hughes Medical Institute, canceling its diversity programs, the National Academy of Medicine taking down, which has just done heroic work in chronicling disparities, taking things off its website. And even me, as someone that had been reporting on this and written many of these stories that we linked to, it was just kind of breathtaking to see it all in one place. So I think it's really important to notice that. I'm going to try to go to the rest of my slideshow. Is that visible?
Yeah, we're seeing now tracking accountability in government grant system.
This is a HHS little known website that's become outsizely important more recently. This is where they show every single grant that has been terminated. And I know when they teach you how to give talks, they say, never use a slide people can't read. Well, I think that's the point here. There is so much information. There are so many grants being terminated that it's really hard to keep track. And you kind of can see that visibly in this. I think a point I want to make is, and again, not going to scroll through this all for you, but this is page 72 of 73. This goes on and on and on, and it's not even updated. I think this is probably showing grants that were terminated through May. So it's just a kind of a breathtaking amount of loss, of research, of work. And many of these, when you start to read the specific project titles, are related to health equity work. So if you're confused about this, if this is like overwhelming, I don't blame you. You can even look at journalists. These are different headlines from recently talking about the funding cuts. None of them have the same numbers. These numbers are changing in real time. Some of them include anticipated cuts. Some of them include what's been cut. Some of them sort of say about the number of grants that have been targeted. Some of those grants had already been spent out. So what's cut is like a proportion. And so it really leaves even journalists who are tracking this confused. And I think one thing that's really important is to take those big charts and graphs and try to visualize what is happening. Look at the data in different ways so it's not overwhelming. The New York Times has done this really helpful analysis of what types of grants have been cut. This is our typical funding over the 10 years, and this is this year. So you can see how everything shrunk. But what you see different topics: geosciences, computer science, biology, social science. What you don't see is health equity, which I think is a really glaring lack and something we as reporters need to start focusing more on. Again, it's another slide you probably can't read, and I don't expect you to, but the government has not been transparent about things and about what it's cutting. Right now, there's a lawsuit going on in Boston, a court case to try to, resume the funding. And the judge is specifically calling out the government for not even defining what DEI is and asking what they are cutting. This is and we've seen journalists and even scientists and people in the public heroically working to track what is being cut and lost. And this is tiny, but when you go to this website, and I can provide it, you can see these different topics: trans, health related, gender, LGBTQ, and race and DEI. So this is sortable, and you can see, well, how much is being cut under these various topics, other taboos, vaccines, COVID-19, other things that are I guess, wasteful and fraudulent to study right now. But when you parse and divide this, you see that of 9 billion in affected grants, now that's not cuts, that's a total amount of grants, much of which have been cut, but of 9 billion, 4.6 fall under that race and DEI rubric. I'll throw some cautions out because there are, many grants involve race and DEI as well as LGBTQ people, so they might fall under multiple categories, but that is more, even a journalist can do this math, right? That's more than half of the things that are being cut. And I don't think that word is getting out there. The other thing I want to talk about is the federal job loss. And again, please don't worry if you're confused about these numbers. This is an updated story, June 6th, 59,000 jobs gone. Another story with 121,000 laid off, and then projections of 1.2. So again, it's a flood. It's an enormous number. It's an enormous amount of work that's not being done. As we've chronicled at Stat, some of these are people that drive people to dialysis. Some of these are people that provide STD tracking in the Great Plains, where some of the tribal communities are just getting really hit with syphilis, that's affecting moms and babies. So all these jobs are gone. Again, it's like, how do you even comprehend this? These are, again, CNN's done a great job. These are different government agencies and the number of people. I can't even fit all the government agencies. There were more, the list went on, but it's just gives you a picture of how widespread this is, and whether it's the CDC or the FDA, which we have heard a lot about, FEMA, many of these our agencies that work on health disparities and health, they do health equity work and work on really important topics. And I think that's worth probing. Again, you look at CNN looked at what types of jobs are being lost, but everything's so vague and broad brush right now, like a nurse. I mean, I'm sure many of those people work on health disparities issues, but we don't know. So I think that's one key thing to do is drill down and get detailed and get specific, like who are vanishing and what work are they doing that's vanishing. Live shot of of me trying to understand all this every day since January 20th. That's what I look like at my desk. At STAT, we are small. We don't have huge teams, like the amazing teams at ProPublica and the New York Times. But because of this unprecedented like rollout of material, much of it happening like Friday at 4 p.m., 5 p.m., 6 p.m. Eastern, we have these cute cartoon bylines, but we are often, I think this just shows we are often teaming up and half of our staff will be on one story. I think we hit the limit at March 28th, at which point we were loving it. We wanted like the cartoons to go all the way across, but our editors were like, no, we're just going to start putting staff on these bylines. And I'm eager to hear from our other panelists, but I'm going to say briefly places I think reporters can go from here who are interested in looking at like the huge health disparities in our country. And I'm happy to answer more questions about this later. But I think we really have to focus on health equity and health disparities. This is a topic that has been lost within mainstream media, has been lost, within mainstream medicine, has been lost within, the NIH only 5 years ago realized it was so underfunding this area and had to apologize for it. We now got some traction, there's a number of reporters covering it. NIH funded it in large, increasingly larger grants about 5 years ago. And that's losing traction now, but these cuts are decimating the work. And I think it's really important that that doesn't get lost in the fire hose of information. Look at the money, look at the jobs. There's really simple stories to do, like what did that military parade cost and what could that pay for? Who's not working, who's not driving someone to dialysis, who's not tracking a really important data set? That needs to be tracked. There's just so many stories out there. There's no shortage. So really, people have to be jumping on this and alert and keep that flow of stories going. Don't be too narrow into just like health equity and health disparities work. The environmental justice work is being cut. Work on climate change that floods, poor communities in the South. Job programs where, many of the federal workers, it's a largely female and Black workforce, and many of the people laid off are really being harmed. And that, we know poverty translates into poorer health, pollution, all of these topics. I think anything in my work seems like any health issue I look at, there are disparities in it. So really any topic you can think of, you're going to find that. Look for the warriors. Look for the warriors, people like Dr. Peak, Dr. Benjamin. People are going to continue to do this work. They are not stopping, no matter what the federal government throws in their way. So there's going to be stories to write, and communities that are harmed are going to keep doing the work. And a lot of this work, again, was funded 5 years ago and has gotten started. So that work is going to continue and find ways to do it. And my last thing I want to end on is to say, humanize the stories. That we were talking about tens of thousands of people laid off and billions of dollars in grant money lost. But one thing we did for 100 days was we found, one researcher, Jamie Slaughter Arcey, whose maternal mortality grant, young researcher, got a huge, incredible grant, was cut. Josh Fessel, a top leader at NIH, who got so sick, kind of revolted by what he had to do under the new administration and cutting really important clinical work he cared about, that he just had to quit under what he called moral duress. And I think taking and humanizing those stories and showing the real toll on the ground is one way to get across that this is really happening.
Yeah, thank you so much, Usha. This is really a great way to start our conversation. I also just want to acknowledge some really interesting comments in the Q&A. I'll just read out a few of them because this is really a bigger conversation, of course. And so there were, as I mentioned earlier, some concerns about lack of access to data. Janet, and I apologize in advance if I'm mispronouncing your names, but Janet Vopel Moody said the public is unaware of what programs are supported by Medicaid. Esther Dyson spoke about reckless disregard for irreparable damage to real people. And Catherine Haynes said health equity officers of Medi-Cal health plans in California, a position contractually mandated by the Department of Healthcare Services, are struggling to decide whether to change their titles and reframe their work so they can continue to do it. Yeah, I just think this is just and then I wanted to also acknowledge Michelle Magar, who says disability rights is somewhat under the radar. Is that also true? Or are health equity cuts also specifically addressing people with disabilities? And where can we find data about the specific impact? And we'll come back to that in the Q&A. Thank you, Michelle. We're going to turn now to Dr. Benjamin. And, in this kind of moment of really dizzying set of, changes, it's hard to remember that we're just still recovering from the COVID pandemic and that the nation had been working to address, just a sweeping array of chronic health disparities that were revealed by the disproportionate death toll. And I'm wondering, Dr. Benjamin, how do the Trump administration's current policies and actions impact this ongoing work to make health and healthcare more equitable?
Yeah, let me focus in three areas. Let me talk about the issue broadly, to remind us about COVID, and then talk about what the Trump administration is doing. So first of all, just remind you, we spend almost $5 trillion annually on healthcare in the United States. Only about 3% of that's on public health. But we also, when you compare us to other high-income nations, we're at the bottom of all those other high-income nations in terms of overall health outcomes. And there's actually probably four reasons for that. Number one, the fact that we have a system that doesn't have everyone in and no one out. I'm not talking about single payer per se, but we have a phenomenal, we use insurance as our coverage mechanism, and yet we still have millions of Americans who are uninsured. And an even larger number of people who are underinsured, meaning they have an insurance card, but they can't afford to use it in many cases. Other nations spend a lot more money on the social determinants, the fundamentals. During COVID, they compared us to other nations, but they had universal long-term care, they had universal access to care, they had universal child care. We don't spend as much on social determinants of health, social services. And in fact, that accounts for more money being spent on the healthcare dollar, actually. Third thing is that our emphasis on primary care, we don't have enough of an emphasis on primary care as others. And that's important because at the end of the day, if you want to deal with primary care, you want to deal with chronic diseases, on the medical care side of that, primary care is the secret to addressing good chronic care. And public health is the secret to making sure that you have less chronic care, because you can get people to be less sick to begin with. And then the fourth area is that we just have this fractionated system. We pay the fractionated payment system, fractionated delivery system. It impacts all the other systems. Fractionated payment means people sometimes get care, sometimes don't get care. We spend over 20% of our healthcare dollar, of that $5 trillion, almost $5 trillion, on administrative costs, at a time when banks have gotten their processing fees down to essentially zero. So just park that as a thought. The 10 leading causes of death in our country are heart disease, cancer, unintentional injury, strokes, lower respiratory diseases, meaning chronic obstructive pulmonary diseases, often from tobacco use, and asthma. Sometimes pneumonias go into that, but it's mostly this chronic lower respiratory disease syndrome, Alzheimer's, diabetes, kidney disease, chronic liver disease, and cirrhosis. In the past, alcohol had played a big role in that, but things like hepatitis C is a growing component of chronic liver disease. And then COVID-19, which of course has a chronic disease state. It actually used to be the third leading cause of death during COVID, and then it dropped back down once COVID moderated. Although remind you, COVID's not gone yet. So those 10 leading causes of death. And historically, communities of color, African Americans, Hispanics, in particular, non-Hispanic, when compared to non-Hispanic whites, had more of these diseases than non-Hispanic whites by 2 to 3-fold for most of them. In fact, almost all diseases, except a few targeted diseases that might be based on race, ethnicity, or gender, tend to be disparities based on race. Race is a surrogate for a lot of other things, but granted, it's a social construct, but it does sort out that way. And the only thing actually, when you compare African Americans to non-Hispanic whites, was that whites had more suicides than African Americans. And what's important to know is that that gap is narrowing as more and more African Americans begin to commit suicide, mostly with guns, by the way. We also know that while there have been improvements over time, I mean, the health system has done it, and public health system done a marvelous job in bringing down overall, people living longer, bringing down death and disability that's premature. COVID reversed that dramatically, including with gaps. Now that, again, COVID is moderated, we've returned not quite to pre-COVID morbidity and mortality, but there has been some reversal in that. And what we really need to understand is that the administration now has done a couple things. They have decided that diversity, equity, and inclusion and focusing on health equity is somehow discriminatory and undermines the health of non-Hispanic whites. And they've said that is a discriminatory practice. They will not fund it. They will not support it. And so they've gone after that. And what they've done, of course, is confounded Supreme Court decision on affirmative action, which is a very different issue, with health equity, diversity, equity, and inclusion. DEI is exactly what it says. It's around making sure that you have diversity. It's about, so everybody's at the table, including urban, rural, men, women, young, old. It is really an attempt to look at your population and make sure it represents the whole of society. Inclusion really means asking the fundamental question, who's not in the room, whose voice is not heard, and how can we get them to the table? How can we get them included? Because far too much of our work excludes people specifically. I mean, a lot of research is simply done on older white men. It excludes women. We have a huge hole in research around women. We have a huge hole around research in rural communities. We don't do a lot of good research on people with disabilities and people with intellectual disabilities for a variety of both ethical reasons as well as functional reasons. We don't know a lot about their needs as well as much as we ought to. Let me say that tell one story, and then I'll talk about what the Trump administration is doing with their reorganization of HHS. When I was a health officer in Maryland, every health officer, every year we look at infant mortality. There's always some kind of gap. Infant mortality has been something we've been struggling with to try to close the gap between African Americans and whites. But this particular year, we had a sudden increase in infant mortality in Maryland. And it turned out it was not the usual population. It was not low-income minority adolescents. It was in well-insured African-American women who are now seeing babies that were not surviving throughout their first year of life. And it turned out that what had happened was, now that there was more eligibility for fertility treatment, these women were getting a lot freer access to fertility treatment. Fertility treatment often resulted in more babies, smaller babies, higher infant mortality. And in this case, our data picked it up as a really large spike that stayed around for a while. But what was interesting, when we really looked into the data, we discovered we had missed it in whites in the state, because the spike was shorter and didn't last as long. And there are probably access and funding and all kinds of reasons for that fact that whites did better overall. But by doing a look back, targeted by the fact we found a problem in African Americans, we were able to put in a broader policy which helped everybody. We see this a lot in health equity. When we discover something that impacts a particular population, we then invest everybody. Now, what the Trump administration is doing, a lot of platitudes, a lot of discussion around wanting to deal with chronic diseases, and yet they're doing a couple interesting things. Number one, they are combining the Substance Abuse Administration and the Health Resources and Service Administration, who are both medical care delivery entities within HHS. And they are eliminating all of the public health chronic disease programs at CDC. So they are medicalizing prevention and wellness. And they're saying that what they're going to do is improve the health and well-being of chronic diseases by treating people when they get diseases, including eliminating such things as the breast and cervical cancer program. So we won't be screening, picking up cancer early. We can talk about more details, but they're constructing a nonsensical organization which is medicalizing public health and prevention and totally eliminating tobacco programs, a leading preventable cause of death, as another example. And then they're pulling the money out to actually support those programs. So I'll stop there, but just to point out that, give you a kind of a broad background of what chronic diseases are. If you're really serious about addressing the 10 leading causes of death, all which are chronic diseases, you have to have a balanced portfolio of prevention, wellness, and treatment.
Thank you. Thank you so much, Dr. Benjamin. This is really illuminating. We're going to turn now to Dr. Peak, and then we'll take your questions. And if you want to put some questions in the Q&A, we can turn to them probably in about 10 minutes. Dr. Peak.
Great. Thank you so much. I am having some technical difficulties, so although you all can see me, I can't see really anything. Hopefully my slides are getting loaded. I sent an updated deck to make sure that I have enough time for Q&A, so I shortened the deck. And so, Ryan, I hope you got the revised slides and are loading them now.
We can see them, Monica.
Okay, excellent. All right, so I'm going to move to the first slide, which is just to acknowledge that James Baldwin will be with us today. I'm using one of his, I'll start with one of my favorite quotes from him, which is that we can disagree and still love each other unless your disagreement is rooted in my oppression and denial of my humanity and the right to exist. And so I think that that is a good way for us thinking about our national discourse and the idea that it's okay to disagree, but we can't have disagreements that are saying that some people don't have the right to have their full humanity and some people aren't allowed to live in this country, and you know, those kinds of things. I think that's where we are. One of the things that I want to do is take a step back even further and talk about the broader implications of what's happening around equity and why is this happening right now. Like, it's mean-spirited, it's not right, but what's the connection between this? So I'll say next slide. One one of the things that I think most of us have either realized for a while or realize right now is that we are currently a flawed democracy. The Economist has been tracking this for a bit, and we have been rapidly moving towards an authoritarian state. And part of the reason, there are many reasons for that, but one of the things as a democratic institution that we have is the idea that we're committed to pluralism. And that means that we, no matter what our social identity is, our race, religion, national origin, creed, sexual identity, gender orientation, that we have all agreed we're going to live here together peacefully and, govern together. And that societal contract is fraying, it may be on fire. And so our sense of pluralism has taken a nosedive, and that's a core democratic ideal. Next slide. And so this just shows that for a while, this back in 2023, that sort of where the United States stood in comparison to other countries around the world as far as our democracy, and it's much worse now. Next slide. And so the implications, what are the implications of being less than a robust democracy as far as health equity? So less democratic countries have more violations of human rights. And those violations of human rights are disproportionately borne by more vulnerable communities, by more marginalized populations. So women, racialized minorities, or the ethnic group that's not in power, the religious groups that are not in power, sexual and gender minorities. And that is what we're seeing in this country. And in particular, healthcare is a place where we're seeing a lot of these issues sort of played out. And increasingly, we're seeing the physical and socio-political sites of attack happening more and more, where we previously hadn't seen that in this country previously. Next slide. And so what we've seen are changes in women's access to reproductive rights and abortion care. George's Benjamin was just talking about affirmative action that has huge implications, including the pipeline of physicians. The anti-DEI ban has broad sweeps as far as implications for education and programming, rollbacks in gender-forming care, all kinds of things. Next slide. Why is this also important? So not only are these populations being harmed, but part of the issue, the fundamental issue, is when you have a group of people that are different, or let's say are Black and brown, or that are marginalized for whatever reason, and they have worse outcomes, worse health outcomes, worse educational outcomes. The question is it those people, or is it the circumstances in which they've been forced to live, work, and play? Because society has decided that they should live in the ghetto, that they should have the worst paying jobs, that they should have the most dangerous jobs, that they should not be educated as well. And so their outcomes are going to be worse. And so are we going to explain it away by it's the people themselves? Or are we going to take a broader look at the inequities in which we have superimposed for those people? And that's why, and that's the problem. And what we have come to, next slide, in this country is sort of the realization and the sort of public acknowledgement that it is the structural inequities that are having a significant impact on the people, as far as many marginalized people. Next slide. And so this is a report that came out from the National Academy of Medicine that was led by Dr. Benjamin. And I was fortunate to be on a part of that committee. And this is our conceptual framework that said, when we are looking at health disparities, or when we want to have optimal health outcomes, there's a whole lot of things that happen within the healthcare system that need to be equitable. But prior to that, we have to understand that there are structural drivers of health. There's oppression and structural racism. There are all of these things that are precursors that are shaping our society and the communities in which people live that are determining that outcome. It's not just the way that people look, their sexual orientation, the fact of whether or not they're living in a rural community or not. It's what we're doing to those people that are driving the health that they ultimately are experiencing. Next slide, please. And so that narrative is being challenged. And so it particularly now in light of all of the truth decay that we've seen happening, and in light of all the misinformation that is purposely being put out there as an alternative narrative to what we see on TV, to what we actually know to be true, these alternative facts. There's an alternative narrative to what is actually happening. Next slide. And so the bigger question we have to ask ourselves is, why not work for health equity? We know that countries who have significant income disparities have worse educational and health outcomes for everyone, not just the poor or the racial and ethnic minorities, everyone. And we know that eliminating disparities based on race and ethnicity and low income status would improve the health for all Americans. And it would save us $1.3 trillion, more than that now, because that was based on 2018 estimates. And most of those savings would go to white people. And some significant savings would go to persons of color. So what is it? Why do we have a stake in maintaining this caste system by race, ethnicity, and income? Because certainly we would do better. Our whole country would do better. We would save more money. Everyone would be more healthy if we would try and strive for equity for everyone. And so what is it that we have to gain? And so that's the question that you all should be asking, that everyone should be asking, is why are we forcing ourselves to go back in time to these older systems of oppression, particularly when we had finally gotten ourselves to some sense of agreement about what the underlying problems were, to outline some solutions where people were, getting to be on the same page about how insurance companies were going to start covering certain things around these social drivers and food insecurity. Why now are we going to go back in time and make things worse for everyone in the world? And so we've already sort of had a discussion about the censorship, the infrastructure and resources, the human capital, the scientific leaders, how it's had a tremendous impact on the state of the science, and how that is going to have, impact not just today, but for generations, and what that means for our understanding, our ability to understand disparities and how to solve them. What it means for the impact, not just on the health of the vulnerable populations, but for everyone's health. And so I want us to be intellectually curious about why that is. And so then I'll just end with another quote that not everything that is faced can be changed, but nothing can be changed until it is faced. And we're starting to see scientists from around the country stand up. And so this was a statement by all the editors from various JAMA journals. There's a bunch of them, sort of reaffirming their commitment to saying that we are not going to allow ourselves to be censored by external parties. This was an editorial sort of acknowledging the science of many things, climate change, health disparities, etc. And this was a statement by a bunch of scientists, myself included, that are part of the National Academy of Medicine, that organized nearly 2,000 of us, and had an open letter to the public about the impact of the current administration on science in general, and its public harms. And so what I want to say is that there are many of us that are in positions of scientific leadership that are trying to sound the alarm bells about what is happening in to science in general, and to health equity science. And so thank you so much for having this panel, and I will stop and open it up for questions.
Thank you so much, Dr. Peak. We're going to open this up to all of your questions. There's a lot of statements in the Q&A, I think, because I invited folks to share what they were seeing, but please take this moment to put your questions for this incredible panel into the chat. I'll start with kind of a dilemma that a journalist said she's encountering, and Usha, I don't know if you or others have suggestions on this, but Maria Ortiz Briones said, I was tasked to do layoff Doge stories. My challenge was getting the info of how many employees were laid off and calling media people from those entities. For example, I received that I don't have the info for every question I had, such as how many people would be laid off in our area, and federal employees didn't want to talk. Any tips on how to navigate that sort of situation?
Yeah, it's been really frustrating. I mean, I think the federal government was never really forthcoming with information before, but it's been really hard to get even simple questions answered. Part of that, we think, is because so many communications people were laid off. We've seen like sort of no answer, and now we've seen like they have hired back some freelancers to try to address media. I think you just have to keep putting the questions out and say you reached out. I think it will get better. I think many federal employees are being hired back because I think they're realizing they can't run a system with no people in it. But I think you have to look for outside sources, and it's really hard for government people to speak out. They're getting tracked. You just have to look for outside sources and look at what data you can find. And these incredible scientists are sort of tracking some of the layoffs and some of the grant cuttings. And that's one thing I've been relying on. But it's a frustrating lack of transparency. In addition to the grants that we know are cut, I just was talking to someone at Columbia, and they said, in addition to like grants being terminated, there's grants that haven't been terminated, but when they put in for their funds, they're just not coming. And so someone said NIH is just not paying their bills. And there's absolutely like no transparency about that. So I feel for you. It's just extremely hard right now, but we have to keep pushing.
And, maybe do a call out, do a shorter story profiling one organization, include something where people can call in, might be one way to get responses. But Dr. Peak and Dr. Benjamin, do you have any other suggestions for journalists? And let me just add that we're also planning a webinar on this very question as part of the series, that's going to talk about how you go through some of these databases and weekly reports by the federal agencies and sort them and analyze them. So that's one way. But Dr. Peak and Dr. Benjamin, any suggestions?
I would just say
Go ahead, Monica.
that randomly, I happened to be listening to NPR as I always do, and there was a journalist on there who said she had been overwhelmed by her Reddit account. She had started, I don't know if everyone heard the same story, it was a couple days ago. She was an education reporter, and that by just asking people to sort of tell their stories about people who were being laid off through Doge, that she was getting emails like every 30 seconds. And so I can't remember her name, but the story's on NPR. And so she has now like started covering everything in Doge. And so whatever that database is and whoever she is, she's been pumping out stories, and maybe someone good to contact.
Yeah, that's a great suggestion, to use some of these other channels like Reddit and social media to try and find these conversations and invite them. Really good suggestion. Dr. Benjamin, did you want to weigh in on this point?
Yeah, the federal government doesn't know what they did. Doge, several of these firings were illegally done, where they simply wrote a memo and told you're fired, and people were pushed out of their jobs, or they weren't sure they were fired. They've been put on administrative leave. I mean, the government really doesn't know, because they undermined all of their own data systems, which got corrupted when Doge got into them. So there's a lot of stuff they really don't know. And when people would show up and find out they've been fired and didn't know they've been fired. So my suggestion is, well, I'm sure it's important for somebody to try to do a mega look at all of the systems and what the end of the numbers are. The lawsuits and the various move back and forth that has happened around employees, in my view, means that you would be more effective if you pick a small area so you can talk about impact. So pick a topic and follow the money and follow the people. The lead story where they fired the CDC workers. They said they were going to bring them back, but they never really did. They finally are bringing back the lead workers. This was the story with Milwaukee, where they asked for help with CDC and the people had just been fired. If you didn't know about that story, there are lots of those kinds of stories. There's a story about the COVID funding and all of the workers, well, several of the workers in Lubbock, Texas were fired who were working on the measles outbreak. I think it's can be more impactful to tell impact stories on very targeted areas, because the public doesn't understand what their federal dollars do, and that most of their money actually funds things in their local community and their impact. So if you can help the public connect the dots, I think that'd be very impactful.
Thank you. By the way, Mari Clark says that the NPR reporter that Dr. Peak mentioned was Hannah Natanson, Natanson. I'm probably mispronouncing it, but just wanted to share that with everybody. We're getting a couple of questions from people, really interesting, from different sectors, from journalists and from healthcare professionals, about vocabulary. And this was alluded to by one of the other folks who commented in the chat, which is, how with these words being sort of banned, how are both from the perspective, Dr. Peak and Dr. Benjamin, of folks, seeking grants and trying to do this work, how well is that working? Like, are people just changing the names and changing the language so that some AI tool that's crawling through all this, can't flag things, or just be very interested in that? And then, Usha, for you, do you find yourself in your newsroom kind of revisiting some of the terminology that you've used and rethinking it? Some people have pointed out that some of these phrases that were very much part of the conversation, the dialogue, have now become infused with a lot of negative implications. So, some say that for no other reason, maybe we should change the terminology. So I'd be very interested to hear from you.
I think that's a terrible mistake. They keep changing the bad words. All right, every day there's a new bad word. My advice is these words were never bad. We should ignore them. And we should use all those words. They're all part of the English language. We ought to use them. I think the minute we start doing anticipatory compliance, then we lose. I would argue that the media should not build. My personal view is the media should not do this. You should use the words that we have in the dictionary, all of those words, and I think you should call them out when they're doing this. And all these institutions that are changing their words, and you're right, the reason they're doing them is because they think some search engine will ignore them. But on Wednesday, they're going to change the words again, because their real goal is to stop funding these programs. Their real goal is to really stop it. You need to really be clear about this. They're doing this on purpose. And look, we've seen this before. In 1865, the Freedmen's Bureau was created to address the needs of the newly freed slaves. And then Reconstruction hit, and this is exactly the same playbook to make sure that communities of color disappear as quickly as possible and the support systems go away. And you can call it whatever you want to call it, discriminatory activity or racism, etc. But this is a plan to do this. And I've been pretty clear about my concern that this is intentional and planned.
I'm going to ask Usha to reply, because I know she has a hard stop. And just so you all know, Dr. Peak and Dr. Benjamin have graciously agreed to stay on for a little longer, but Usha, did you want to weigh in on this vocabulary question?
I mean, I think one thing that this term DEI has never been defined. It's just this broad boogeyman term. And, you know, if there's a federal judge right now holding the administration to task over this, we'll have a story on it if it's not up already on STAT. You know, I think as a health equity researcher, you know, when I'm reporting, I mean, DEI is like, it's incredibly important, and it's the kind of work we do at workplaces, but most of the researchers like doing the work aren't talking about DEI. It's not even like a term they use. They're talking about health equity. They're talking about like life expectancy. And so we did do a story early on about the taboo words, and really there's such control F words. They're kind of silly. There's repetition. Words like women are in there. And I talked to one health equity researcher, and she's like, the top like 5 most important words in the field aren't even in this list. And then she said, please don't say what they are, because I don't want them to go on the list to be banned. So this is clearly like someone who has no understanding of the field who came up with this list. So it's kind of vague. And I feel like that, you know, these words were banned in the first administration from an executive order. And I think everyone just like rolled their eyes and went on with work. So it is interesting to see the anticipatory compliance that Dr. Benjamin mentioned, and dangerous. But I just really believe that the work is going to go on. And I see some people I really respect having to not use the words and change their grants because they want to get the funding and they want to do the work and they want to save people's lives. So it's a really difficult time right now. But as journalists, no one's going to tell us what words to use, that's for sure.
Yeah, thank you so much, Usha. Monica, did you want to weigh in on this, Dr. Peak?
Yeah, so I am a senior editor of a journal, and so I think that the academic journals are in a different kind of space, although we see that the government is trying to come after the journals like they are academic institutions. But I think that there is a different kind of academic freedom there. And I do think that it's important that, you know, words matter, that words are part of ideas. And we are currently in a war of ideas, and where there are different periods in time where they're really particularly important. And this is one of those periods of time. And like I was saying that, you know, is it those people or is it the circumstances in which we are forcing them to live? And right now we are forcing people to live under duress. We are doing horrible things to people, and we plan on doing even worse things to people. And we're trying to normalize our country to these horrible things. And so it's really important that we start creating an alternative narrative that says some of these people are just kind of inherently bad, or that they're to create a space where we go back to this biological essentialism, rather than thinking about structural inequities. And so if we're not allowed to say the word structural inequity or structural racism, then that makes it a whole lot easier to fill the void with alternative narratives that are not true, about the quality, the inherent value of human beings in this country. And so I think that it's important that we do not cede certain ground around certain scientific truths and social science truths, and that for those of us who are in spaces to be able to protect that ground, that we do so, journalists included.
I'm going to head out, but thank you all so much, and I hope you have a great continuing conversation.
Thank you, Usha.
Bye-bye.
Dr. Peak and Dr. Benjamin, we have a question from somebody about the dismantling and what they're calling the dismantling of all these like legal medical partnerships and the loss of funding. The person says, this is Michelle Mayer, the entire civic legal aid funding is being eliminated. What impact will lack of free attorneys have on combating discrimination on access to health care?
Oh, they've taken apart the whole capacity of citizens to receive justice or even get their questions answered. They undermined it They say they've strengthened it within HHS, but they're doing everything they can on the civil society side to basically, reduce the services that people were provided. So what's going to happen is, you'll have people that will lose, for example, Medicaid coverage, and there will be no capacity to, unless private dollars fill the goal, fill that void at some point, to appeal anything. The challenge you have, of course, is the private sector. There's not enough money in the world for the private sector to fill this hole. And the other problem is it's happened so abruptly and in such large numbers. The foundations are having trouble figuring out what should they do first. Do they fund with capacity grants just to keep organizations afloat, these small community-based organizations, or these organizations providing community-based supports to people? Or do they put money in larger organizations to build a national infrastructure? And so they're really struggling on what to do and how to do it. At the same time, by the way, their funding is being challenged because of some legislation going through to go after their nonprofit status, as well as taxing some of their reserves. So they're watching an assault on their fiscal capacity to aid communities. At the same time, the administration is saying, we're going to shift this cost to communities, both government and the private sector.
Right. And it's that's just one example. The private sector is also looking to try and buttress all of the research funding that's been cut. As the government is slowly being dismantled, the private sector and foundations are asked to pick up more and more of the slack. But how much private money is there? There's not. And that's not the way that we want our society to function. Our government is supposed to be, a function of us, the people, that serves the people. And so this overhaul and dismantling is not democracy. And we should not be having to turn to, with a handout, alms for the poor, to try and keep basic services for our community afloat.
And I'm going to turn to another question, but I also just want to mention that in our Q&A chat, there have been a number of comments of people kind of agonizing over this question about vocabulary. And I do think it's a very interesting ongoing story to look at those decisions by institutions and nonprofits and individuals. One person said this is not just, this is about our survival. So I think there's some really difficult choices that are going on right now.
Yes. Yeah. I think it also depends on where and how you're being, you're positioned. Because I wear lots of hats. Sometimes I am functioning as an academic who's turning in a grant. Sometimes I'm someone who's submitting a paper. Sometimes I'm an editor. Sometimes I'm a citizen, trying to protect our, country's rights. And so I think the language that we use may reflect which hat we're wearing, but and so I may be altering or my language to varying degrees, but in my core, I am always recognizing what the end game is, what the broader strategy of our current administration is, and trying to see what is the most that I can do sort of within my current environmental constraints to try and stay close to my goals.
Thank you, Dr. Peak. We have a question from Stacy Stukin, who asks, can any of you speak specifically about cuts to nutrition and food programs by HHS and USDA, especially as they relate to food insecure children and community health?
I would say I think that that's that actions speak louder than words. And if we are trying to make America healthy again, we don't do that by cutting food to poor families.
Yeah, they're doing two things. They're dramatically cutting the food program, the commodity supplemental food program. They've also cut the people that help make those programs work. So you cut the money for food, and then you cut the people that actually run the programs. And then the second thing they're doing, of course, is they are going to be looking at the dietary guidelines. And although USDA has the lead on it, as you know, Kennedy's talked a lot about the guidelines and what he thinks the guidelines ought to be. And there's a lot of concern about what he will do. It's not that, if you have to look at the polls, both conservatives and progressives all want to do something about food and healthier food. But you may remember that Mrs. Obama made a big deal about nutrition in schools, and they did not support her. At least Republicans did not support her. So we'll see where that goes, but we're very, very worried about those food programs. But at the end of the day, there'll be more kids not having healthy foods. Anyone who tells you that it's not going to kick people off the program is not being honest with themselves or with us. And we've already got enormous hunger in the country that will happen. And when you know, all these cuts to lower income and people are cumulative. So when you take away their food money and then you take away their healthcare services, and they'll say they aren't, but they will, then you'll just find more insecure people, food insecure. You'll find more people on the street, more homeless, and there'll be a trickle down to that. And they'll save money in the short term, but they won't save it in the long term.
No. And then we know that a lot of people are criminalizing being unhoused. And so people will end up in prison. And that's obviously more costly. And so as a country, are we really thinking about what's most cost effective? Not by the actions that we're choosing, not by our policy choices. Because it's more cost effective to do things that are preventive in nature, that, send our kids to school, that work to make sure that everyone can live a healthy life. But we're really invested in not doing those things. And so really with knowing that there are bad outcomes.
The one thing, of course, is this goes through all of this is this idea of otherism. Is creating these artificial divisions. They're cutting the quote unquote the welfare state, and we can obviously, we all know they want to give a big tax cut. If they want to save money and cut the budget, that's where the cut ought to occur. But that's my view. But the Affordable Care Act, as an example, created. They keep saying Medicaid is a welfare program. It is not a welfare program. It is the nation's insurance program for a large number of Americans. The Affordable Care Act changed it from being a welfare program to a national insurance program on the same par as Medicare, just funded differently. And they're now saying that these people don't deserve it. Most people on Medicaid work. And I saw one in the question in the chat is, no, most people don't know they're on Medicaid. They don't know Medicaid's paying for their long-term care. They don't know that because it's called Kentucky Care or TennCare or something else, and they get an insurance card from a private insurance company, which now manages the program for the Medicaid program. They don't know they're on Medicaid. So they don't know they're about to get cut. They don't know that they're about to be required to document their working. And work requirements have never been shown to work. I mean, it's been never a successful work requirement experiment. They also are underfunding the infrastructure to do work requirements. So they're increasing costs for the program. They're going to kick people off the program. And again, the trickle down of these folks. And by the way, they won't just be low income individuals. They'll be folks that are just at the margins of jobs because they go in and out of employment. They're seasonal employees, they're hourly employees. They're folks that won't be able to document their working because they're working 2 jobs and they got to find a time to get a piece of paper photocopied to turn it in. So it's going to be a mess. And I keep hearing them saying that few people are going to get kicked off the program. Of course, the science has shown that's not true. The experience, everyone who's tried to do work requirements shows that these folks fall off the program in droves.
And of course, Dr. Benjamin is talking about the big, beautiful bill now making its way through Congress. And one of the most likely ways that Medicaid is going to be affected is adding work requirements. And there's been some very interesting responses from both legislators in red states and blue states, because some red states have a very heavy reliance on Medicaid, and some past examples have shown that when you start adding a work requirement, the consequence is that many people who are legitimately working, and of course this is being done in the name of eliminating waste, fraud, and abuse, but many people who are legitimately working have trouble navigating that additional requirement, and so they lose their coverage in any case. But I think we maybe have time for one more question, if you'll permit me, Dr. Benjamin and Dr. Peak. And this is asking both of you to reflect on the longer term implications of current policies, such as undermining access and confidence in vaccines and the dissolution of USAID. Not a small question, but maybe each of you can take a piece of it.
Well, let me give you something that should scare you. Okay, this should scare you. So they cut USAID and HIV funding. By the way, people are dying already, documented deaths, because of withdrawal of support for people with HIV. But here's what we know about antiviral drugs. They have to be taken as directed. So when I first got into public health, we didn't even know what AIDS was. Now we have finally got to the point that we can totally stop transmission of HIV/AIDS from one person to another. I mean, totally stop transmission if people take their medications. But the other thing we know is that they don't take their medications regularly, you'll get drug-resistant HIV. And we saw the same thing with tuberculosis when we suddenly withdrew funding for tuberculosis. Now we have drug-resistant tuberculosis, much more difficult to treat. And so imagine a world with drug-resistant HIV when a couple years ago, we could totally stop transmission of the disease. In an epidemic that is continuing, it's actually still a pandemic, and pass by the usual pastime of sexual engagement or blood transfusions. I mean, this is a nightmare waiting to happen, and it don't take too long for it to happen.
Yeah, thank you, Dr. Benjamin. Dr. Peak, did you want to weigh in on this last question?
Yeah, I am on the board for Physicians for Human Rights, and I went to Kenya in March. And the impact was immediate, because just like things here, it's not just the money for the drugs. When you fire the people, or just even have them unemployed for a short period of time, they have to take another job. They have to feed their families. So even if later the judge says, you know what, that was wrong, put those people back, they have left. They've left. And so, it's not, so yes, there's multi-drug resistant TB and HIV. There are other things that those programs were keeping in check. So Ebola and other kinds of hemorrhagic diseases that we're trying to, keep a tight lid on. And we learned from COVID how quickly person zero goes to all around the world, because, we're a global community. And if if we have not learned that lesson over and over, how fast something can go from, a very rural community deep, in a nation far away to an urban city in this country, in the implications of us being invested, not just for, political goodwill, our national security, but also for our own physical safety as far as the spread of infectious diseases. Again, all of this is counterintuitive to common sense, the way that we are not investing, pennies on the dollar and keeping ourselves safe. And so that is just a nightmare in and of itself. The fact that we have been working tirelessly, for decades to rebuild trust in communities, for all of the mishaps that our government and public health system and healthcare systems have been doing to vulnerable communities. Trust us, please. We need these COVID vaccines, get behind the umbrella of safety. And now, all the shenanigans that are starting to take place under the name of our government, it is unclear how long it will take communities to trust our government again.
Well, thank you, Dr. Peak and Dr. Benjamin, and of course, Usha. We're going to end on that really sober note. I also want to thank the audience for all of their great questions and the conversation. There's clearly so much more to explore. And just know that we have a number of additional webinars coming up under this Health Equity and Health Systems framework, thanks to support of the Commonwealth Fund and the California Endowment. I also want to thank Ryan White, our content editor, and Apps Mandar Bishu, our communications strategist, for all their help behind the scenes. We'll be emailing you a survey asking for your feedback on today's program and for your ideas on other topics of interest. Please take a moment to complete it. We also urge you to help support these webinars. You can find more information here on how to do that. And we got a number of questions about this, and we will be archiving this webinar and the PowerPoint slides a little later today at centerforhealthjournalism.org, and you'll receive an email with the link. Thank you so much for joining us, and have a wonderful day.